Dr. Nordin, you're welcome to start.
Good evening and welcome to this SADA webinar on bleeding disorders. I'm Naima Noureddin and will be your host this evening. To start off, I'd just like to go through some house rules. Please refrain from using the raised hand, but type your comments and questions in the Q&A tab. CPD certificates will be located or loaded to the HPCSA platform, and you will be able to access all your certificates under your profile. This event for tonight qualifies for 1 clinical CEU. Just a reminder to please complete the evaluation after the webinar. Tonight we have 3 members on our panel, that is Prof. Lowe, Dr. Elzanne Jansen van Rensburg, as well as Dr. Veronicah Orina. Prof. Lowe is a chair and head of the Division of Clinical Hematology in the Department of Medicine at the University of Cape Town since April 2018. He held previous roles as professor and head of the Department of Internal Medicine at the Faculty of Health Sciences at the University of the Free State in Bloemfontein since 2013, also the head of Division of Clinical Hematology from 2004 to 2013. After completing his MBCHB and M.Med in Internal Medicine at the University of Stellenbosch, both summa cum laude, he went on to do his PhD in Health Professions Education at the University of the Free State on the development of postgraduate training program in transfusion medicine. In 2015, he received the National South African Registrar Association Award for Excellence in Teaching and Research Supervision. His research focuses on iron-related disorders, both iron deficiency and transfusional iron overload, patient blood management, transfusion medicine education, heme malignancies, and HIV-related hematological disease. Professor Lowe has co-authored and authored many peer-reviewed papers, also many poster presentations, as well as contributions in textbooks. Just to note, I had to summarize Prof. Lowe's CV quite a bit because it was quite the introduction. And we'll get to hear from him later. Our next speaker would be Dr. Elzanne Jansen van Rensburg. Her lecture topic this evening is Hereditary Haemorrhagic Telangiectasia, or HHT, and the Dental Health Practitioner. She qualified in 2018 with an MBCHB from Stellenbosch University. She also has a diploma in anesthesia. Currently, she's a medical and research officer at the Division of Hematology, Groote Schuur Hospital. She's working within a well-established team. Her research in HHT is part of her undergraduate thesis. She did a study with the title HHT Diagnosis, Management and Prognosis in the Low-Resource Setting. She presented this thesis at the International Cure HHT Scientific Conference in Croatia in 2017. She presented the same work at the South African National ENT Congress in Cape Town in 2017. She was a sub-author on 2 HHT poster presentations with Dr. K. Ace and Dr. J. Barnard at the HHT conference in 2017 and 2022, respectively. Currently, she is involved in ongoing research and projects in HHT at the University of Cape Town. She did her internship and community service at Heidelberg Hospital. In the work setting, her interests are HHT, anesthesia, and research. Outside of work, she enjoys rock climbing, sailing, and camping. Our third speaker or panelist for today is Dr. Veronicah Orina. Her lecture topic is a general approach in dentistry in patients with hereditary bleeding disorders. Dr. Orina is a dental officer working at the Defence Force Memorial Hospital in Nairobi, Kenya. She graduated from the University of Nairobi Dental School. She is passionate about clinical work, research, and all interactions that involve a link between the two. She has an interest in writing, in special care dentistry, and in participating in forums which offer a voice to oral health promotion. She is currently doing a 6-week program at Groote Schuur Hospital in the hematology department on the holistic care of patients with inherited bleeding disorders. So without further ado, Dr. Orina, would you like to share your screen with us, please?
Thank you so much, Dr. Nurdin, for that wonderful introduction. Just a minute so that I can share my screen.
Not a problem.
All right. Please confirm if it's visible.
It's not visible yet.
All right.
You can turn your camera off, Orina.
Yes.
And then you can just load your screen. I think it will load faster.
Is it visible right now?
Okay, it's visible now, but please present your view. There we go.
All right, thank you very much. Thank you so much, Dr. Nurdin, for that wonderful introduction. My name is Dr. Telangiectasia Orina, and I'm very happy to be here. So today I'll be taking you through the dental care for patients who have inherited bleeding disorders. So my outline would be the overview of the bleeding disorders, the classification, the general clinical manifestations, the examples and oral manifestations of those examples, and the general management and the implications when it comes to dental care. So bleeding disorders, they affect the body's clotting factors, and there are some which cause structural abnormalities. So those that affect coagulation, they lead to prolonged bleeding upon injury. So currently, the research says that 90% of the hereditary diseases are made up of hereditary coagulation factor deficiencies. So just a broader classification, we have 4 types. There are, number 1 is the coagulation factor deficiencies, and such as hemophilia and von Willebrand disease. And there are also platelet disorders, which can be quantitative or qualitative. An example of a qualitative disorder is Glanzmann's thromboasthenia, and an example of a quantitative disorder is thrombocytopenia. We can also have vascular disorders such as hereditary hemorrhagic telangiectasia, which is going to be one of our main focuses today. And we can also have a fibrinolytic defects such as disseminated intravascular coagulopathy. So generally, we can classify these bleeding diseases into acquired bleeding diseases and inherited bleeding diseases. So these are the examples of acquired bleeding diseases, and they include DIC, absence of factor 1, 2, and 5. We can also have liver-associated bleeding disorder. We can also have vitamin K deficiency bleeding. And we can also have a bleeding disease that is caused by arteriovenous malformation complications. And you can also have hemophilia and von Willebrand disease that are as a result of acquired bleeding diseases. So on to inherited bleeding diseases, which are our main focus today. We have HHT, we have hemophilia A, B, and C, and we have von Willebrand disease. And the first 3 are going to be our main focus today. And we can also have combined deficiency of vitamin K dependent clotting factors, and you can also have deficiency of other clotting factors. So for today, we're just going to be biased with coagulation factor deficiencies and vascular defects. So onto our general manifestations of inherited bleeding disorders. Number 1, we can have prolonged bleeding, which may be spontaneous, and it's actually dependent on the severity. So the triggers to this bleeding can be such as trauma, dental surgery, or nose bleeding. We can also have oral hemorrhage, which can be as a result of dental extraction or gingival diseases or trauma. These patients also manifest with heavy menstrual periods, and they can also manifest with having blood in urine or blood in stool. And another manifestation can be petechia, telangiectasia, ecchymosis, or purpura. And another manifestation, most especially in hemophilias, is pain, joint swelling, and stiffness. So for newborns, most especially those who have severe inherited bleeding disorders, you can have umbilical stump bleeding, which persists for 1 or 2 weeks after being cut. So these images are a depiction of purpura, petechia, and ecchymosis. So there is a difference between these three in that petechia has a smaller size. It's a pinpoint lesion, which is usually less than 4 millimeters. And purpura is a larger lesion than petechia, about 4 to 10 millimeters. And you'll find ecchymosis is 1 centimeter and above. And it can be caused by these inherited bleeding disorders or sometimes trauma, most especially during ecchymosis. So for the first image, a patient with petechia can, with HHT can present with petechia on the tongue. And these other 2 images just depict that all the patients with bleeding diseases can manifest with purpura and petechia or ecchymosis. So just a general overview on the diagnosis of these bleeding diseases is number 1, the medical history. So all the manifestations we've talked about previously, your patient can complain of these presenting complaints. So you have to ask about the medical history, and then they'll have a positive family history of either prolonged bleeding, easy bruising, joint stiffness if it's hemophilia, and number 3, you'll have to do like a physical exam. So on physical examination, you're going to find the lesions that we have talked about previously, which can be purpura, ecchymosis, or it can be also be prolonged bleeding when you're doing, for example, an extraction. And the laboratory investigations, which usually are done in order to determine the diagnosis, include a complete blood count, activated partial thromoplastin time, prothrombin time, INR, and von Willebrand tests. And the rest are just some of the tests that are also carried out to help out in the diagnosis of an inherited bleeding disease. So with me, I have pictures, and they do not necessarily mean that, it doesn't mean that a patient with a bleeding disorder will have this, but a patient with a bleeding disease may be predisposed to having this due to number 1, poor dental hygiene. So on the top right is a patient with dental caries, and on the top, on the bottom right is a patient with gingival diseases. So these patients, they usually tend to fear practicing good oral hygiene because they fear trauma or bleeding from the gums. So on my top left is a patient with an over-retained 7.5, and when you ask this patient why they have delayed to come to the dentist, they just say that they usually fear extractions. So this leads to them having an over-retained tooth, and definitely growth of the permanent tooth in the wrong direction. And so we can also have a patient with a retained root who is just afraid to go to the dentist because they fear bleeding. So it's not necessary that a patient with this will manifest with this, but having a bleeding disease can predispose our patients to all these kinds of dental issues. So the general management principles, first of all, will be adequate planning for your patient for every procedure. The planning will involve, prior planning and during dental care and also after dental care. So you have to equip your clinic with the following local hemostatic agents. It's not a must to have all of them, but if you have some, at least it will help you when you're managing a patient who has an inherited bleeding disease. So such examples are like the gelatin sponges, like Surgicel, like tranexamic acid, aminocaproic acid, and fibrin glue, and topical thrombin. So the tranexamic acid and aminocaproic acid, they are antifibrinolytics, and these ones you can give them prior just for prophylaxis, prophylactic measures. So you can also do local pressure application, sometimes in combination with your local hemostatic agents. And number 4, when you have when let's say you have extracted when you have had, let's say, a difficult extraction and you have had to open a flap, you should do suturing to at least try and achieve hemostasis for these patients. And just to be aware of also the systemic agents that are usually are administered in the treatment of these patients. We have platelets, but that's specific for platelet disorders. You can also have fresh frozen plasma. You can have cryoprecipitate, factor 8 and factor 9 concentrates, desmopressin, which is DDAVP. You can also have epsilon aminocaproic acid and also tranexamic acid. So just to be aware that these patients, you can treat these patients with local hemostatic agents and systemic agents too. So this is a table that I got from a journal, and it's trying to show you patients that are at a high risk of bleeding after your procedure, and those ones that are at low risk of bleeding during a procedure. So for procedures like anesthesia, giving anesthesia, for procedures like endodontic procedures, like cleaning and impression taking, those ones are not invasive and you do not expect bleeding. But for some patients like simple extractions and like when you're doing root planing and when you're doing restorations that are involving the subgingival margins, you are definitely going to expecting some level of bleeding. And some procedures that predispose the patient to, a high risk of bleeding include complex extractions and any type of surgery, be it periodontal surgery or dental implant surgery. So the considerations that you take in place when you're doing a procedure for a patient, for such a patient, include the type of the bleeding condition and the severity of this condition. So for the local anesthesia, when you're doing an inferior alveolar nerve block and the lingual nerve block, for example, it's a patient who has hemophilia, the WFH actually recommends that the patient has a factor before you do your procedure. You are actually safe doing it when they have had a factor placement 30 minutes to 1 hour before the procedure. But when a patient has a mild form of this disease, you can get away with doing your backhaul infiltration, intraligamental and intrapapillary anesthesia techniques. You can also have restorative procedures, but these ones now you get if they're going to induce, if it's a restoration that is going to deeply involve the subgingival margin, or if it's a restoration just around the tooth area. We can also have periodontal procedures, high risk periodontal procedures, or low risk. For instance, a procedure like scaling, if the patient is a mild, has a mild form of this disease, a procedure like scaling, you may not need factor administration, but you may just get away with oral tranexamic acid administration before the procedure. But if you're going to do a periodontal procedure that involves either a crown lengthening procedure or a flap raising, then you're having these patients get treated before with a systemic agent. So that applies to extraction procedures, and that also applies to prosthodontic procedures. But when let's say you're doing a prosthodontic procedure that involves removable partial denture, it's not an invasive procedure, then you're definitely safe, not having the factor. And then you can also have orthodontic procedures, and these are not actually contraindicated when a patient has a bleeding disease. You just have to coordinate well with the hematologist and assess the risk of bleeding, and then you can just do it. Orthodontic procedures are not contraindicated when a patient has a bleeding disease. So one of our most common examples are hemophilia. It can be A, B, and C. When you have a deficiency or absence of factor 8, then that's hemophilia A. When you have absence or deficiency of factor 9, that's hemophilia B. And when you have a deficiency or absence of factor 11, that's hemophilia C. So I'll just, focus on the oral manifestations, because that's our area and that's where we, are usually as dentists. So this patient may manifest with a severe If the patient is a severe hemophiliac, they may manifest with spontaneous bleeding, gingival hemorrhage, and even oral hematomas. They can also have cases of easy bruising upon minor trauma. These patients may complain of bleeding from multiple sites in the mouth, such as the oral mucosa, the buccal mucosa, and even the lip. They may also manifest with epistaxis, and they may have periodontal diseases as a result of the poor oral hygiene. And they may also manifest with the tongue and palatal purpura, as we previously saw, and ecchymosis also, and oral ulcerations. So the management and considerations to take in when the patient has hemophilia is, number one, first of all, usually focus on the preventative aspect by doing good oral hygiene instructions, diet counseling for these patients, fluoride therapy, and also doing fissure sealants for the permanent teeth. And also when you're doing a high risk or low risk procedure, you have to ensure that they get a factor infusion, depending on, you know, the severity of the procedure, that they get the factor infusion 30 minutes or an hour before the procedure. And you must make sure that, you know, you have your antifibrinolytics, you know, they can be given prior or, you know, as a prophylactic measure. And then they are usually contraindicated when you are giving prothrombin complex concentrates. And also the type of sutures to use are absorbable sutures, and you can also use a surgical stent after an invasive dental surgery to fasten the healing process. And we usually use suction most of the time, so we can try as much as possible to avoid the high volume suction, because they tend to, you know, cause ecchymosis and hematomas on the oral mucosa of the patient. And when you're using appliances such as the rubber dam and wedges and matrices, we just have to be careful in order to minimize the risk of soft tissue laceration. And our next common bleeding disease is von Willebrand disease. I found this picture here, and it speaks actually a lot. The picture on the top left, it's a doctor looking into the nose and mouth of a patient, and they're saying, I see your von Willebrand factor is low. So for me, it hit me because it's just trying to symbolize that you as a dentist who is looking into inside the mouth of a patient, you can actually tell a lot from what goes on. So the oral manifestations of von Willebrand can be tongue and palatal purpura, oral hematomas, spontaneous and excessive bleeding, and gingival hemorrhage. So von Willebrand disease, you can have a type 1, which is mild, type 2, which is moderate, and type 3, which is severe. And for mild von Willebrand patients, usually before a dental procedure is usually gauged, but most of the time they're given desmopressin. And for moderate to severe forms that are usually actually treated like hemophilia A patients, you can also make use of adjuncts such as tranexamic acid and aminocaproic acid. So the last example was thalassemia, and I thought it was important because this is when a patient has a defective hemoglobin production. It can be thalassemia major or thalassemia minor, and we have subtypes such as alpha, beta, and gamma subtypes. So onto their oral manifestation. On this image here, we have oral hemorrhage, but you can also have other symptoms which actually are among the symptoms of aplastic anemia. You can also have gingival hyperplasia, oral candidiasis, oral and facial petechiae, oral mucosa ecchymosis, and spontaneous gingival bleeding. So other oral manifestations include burning mouth syndrome, discolored teeth, because there'll be deposits of hemosiderin as a result of continuous long-term bleeding. These patients may also manifest with short crowns and roots and a chipmunk face because of an overdeveloped maxilla, and also mucosal pallor and atrophic glossitis. The photo here on the bottom right is depicting a patient with atrophic glossitis. So the management and considerations are antibiotic prophylaxis, most especially when these patients have undergone splenectomy, and we're usually advised to avoid aspirin actually for all the patients who have bleeding diseases because it interferes with the platelet function. And you also, when your patient has a crisis, you should avoid treatment for the patients with thalassemia. And orthodontic treatment, as stated earlier, is not contraindicated at all for patients who have bleeding diseases. And also, as usual, we are always advised to consult with the hematologist and other clinicians who are involved in this patient's care. So I just wanted to highlight something on tranexamic acid because it's proven a very important drug, and not as, and it's an important drug as well as other drugs which are systemic agents such as factor and all that. So the mechanism of action of this drug is that it inhibits formation of plasminogen, which also usually facilitates the formation of fibrin degradation products. So this drug has comes in 3 formulations. We have an IV formulation. There's a oral administration, which we usually use most of the time as dentists, and there's also a mouthwash formulation. So these are the dosages of these drugs, and the oral tranexamic acid may have side effects such as headaches, backache, abdominal pain, fatigue, fever and chills, anaphylaxis. And so it's just good to be aware of these side effects also. So the role of a dentist when managing a patient with a bleeding disease is, number 1, we need to be very aware of this condition and the dental care implications. And as we are aware of this condition, we need to give our patients proper education. And also, when you've asked the history of your patient and you've known that they have a positive family history, also advocate for screening for the other members of the family. And also, it's upon us to manage oral bleeds well and any complications that may arise during the dental procedures. And also, it's also upon us, I know all of us, have practiced good dentistry. It's upon us to give appropriate dental treatment before, during, and after for these patients. And also, we also have a role to actively participate in the multidisciplinary management team for these patients. And we also should be aware of the contraindicated drugs in hemophilia. These are mostly NSAIDs and aspirin because they interfere with platelet formation as stated before. And so for emergency care, you can be sure to equip your clinic with the local hemostatic agents and also be in communication with the hemophilia treatment center. So I found this article on a dental implant therapy on a patient with von Willebrand disease. So actually, as I was looking through, there is no procedure that is contraindicated. So long as you have a good communication with the hematologist and they have good factor cover, any procedure is actually possible for dentistry. So home care for a patient who has a bleeding disease, we should always advise them to avoid aggressive brushing and avoid triggers such as trauma and consumption of extremely hot foods. And what to do in case they have an oral bleed, putting pressure on that, and also use of cyclocapron, and also to go to see their primary physician on the same. And so this last here is a scenario of a diagnosed patient and an undiagnosed patient before, during, and after dental care. So for the first row, we have a scenario of the first here is before dental care for a diagnosed patient. As a dentist, it's upon us to do adequate planning, consult with the hematologist, and ensure they have had a factor or cyclocapron administration in case they are hemophiliac, or any other systemic agent or oral agent, depending on the bleeding disease. And this here is during dental care to do our procedures as less traumatically as possible. And this here is after dental care for a diagnosed patient. We should give them good education, appropriate post-operative medication, and follow them up during the review process. And the second row here is on a patient who is undiagnosed. we should take a good family history and a medical history and ensure we have appropriate referrals for this patient, and also to try and equip, our facilities with the appropriate measures, hemostatic measures. So these are my sample references. Thank you very much, and I appreciate. Dr. Nurdin, over to you.
Thank you, Dr. Orina. We'll take the questioning at the end. So Dr. Elzanne, would you like to share your screen with us now, please?
Yes, I will. Thank you, Dr. Nurdin. Let's just share my screen.
Okay, thank you. We can see your screen. You can begin.
Yeah. Alrighty. Yes, good evening, everyone. Thank you so much for the opportunity and the introduction. As mentioned by my colleague, I will dive a little bit more into the intricacies of hereditary hemorrhagic telangiectasia. Some might also know this disease as Oslo-Weber-Rendu syndrome, born by the 3 doctors that first described this disease originally. Alrighty, so just a quick overview as to what we are going to look at. We're going to define what HHT is, what are the concerns, what are the diagnoses. We're going to maybe look at some genotypes and some phenotypes and what they might look like. And also what are the implications for dentists and dental practitioners. And then some clinical considerations and recommendations from our side. And then I will have a quick summary. So just for the purpose of the talk, I will just refer to it as HHT because it's quite a mouthful. So HHT is an autosomal dominant genetic disease with the estimated prevalence worldwide of 1 in 5,000. That is, however, not represented by data in South Africa or Africa for that matter, but we are working on it. It's characterized by telangiectasia and arteriovenous malformations at the characteristic sites throughout the body. And the diagnosis can either be made via the clinical Kurosawa criteria or genetics. We actually have access to genetic testing in South Africa. It's quite limited, but it is a possibility. And the management is very much multidisciplinary. It involves a lot of systems. It involves ENTs, GIT practitioners, hematologists, interventional radiologists. It definitely has a broad scope of practice, and we can definitely reach out to the dental practitioners, and you guys can definitely help us in identifying these patients. On that note, HHT itself is quite underdiagnosed, partly because of unawareness and also due to the natural history of this disease. This disease has the tendency to present either quite late. It can present earlier due to severe adverse events associated with mostly the arteriovenous malformations. But sometimes these patients can go quite a long while without knowing that they have HHT or that their nosebleeds might be a problem. And as such, it's quite associated with a significant diagnostic delay. So what is the Kurosawa criteria? The Kurosawa criteria was established. There's an international working group called the Kura HHT organization, and they are known for trying to promote this disease, its awareness, and trying to present some good guidelines for us internationally. So they met up 1 year in Kurosawa, and that's where the name stemmed from. It has 4 components. The first one is the spontaneous recurrent epistaxis and the presence thereof. These patients can bleed quite a lot from their epistaxis, and about 90% of HHT patients have epistaxis. Then you can have the second component, which is the telangiectasia at characteristic sites. These include the oral cavity, the nasopharynx, the GIT, and also the skin, mostly on the hands and the face. And then you have the presence of the visceral arteriovenous malformations. These include in the lungs, the liver, the brain, and the GIT tract, sometimes as malformed or tortuous blood vessels, and even sometimes in the spine. Then you can also have the first degree relative with HHT that could be either confirmed genetically and or posed clinically. So definite diagnosis is 3 out of the 4 or more, possible is 2, and unlikely is 1. But I can't stress enough the fact that this criteria in its clinical entity has definite limitations, especially for our younger population and our pediatric patients. If you have a strong sense that this patient might have HHT, but they don't qualify based on their age or the absence of some of the characteristics, please do not hesitate to refer anyway. Some of the younger patients, even pediatric patients, can have severe morbidity due to especially cerebral AVMs, bleeding and causing trouble for them, and cerebral abscesses. So the Kurosawa criteria is not the end and all of diagnosis. Just remember that. So other clues that these patients might present with, depending on their phenotype and their involvement systemically, they can have migraines, usually with aura. They can have transemic ischemic attacks. They can present with brain abscesses, which is quite a concern for us as practitioners and is quite applicable for the dental practitioner in the prevention thereof. And then they can have bleed and even suffer from strokes. If they have a right to left shunt due to pulmonary AVMs, that's quite significant and long-standing. They can have shortness of breath. They can have clubbing if they have sustained hypoxia. And then if they have a large AVM that burst or has increased pressure, they might actually present with hemoptysis. So some of these patients develop quite large AVMs at the liver. Some of them, most of them is actually quite asymptomatic, but they can have forward high output failure due to large AVMs and shunts. They can have pulmonary hypertension, anemia. This is also mostly iron deficiency anemia, which is quite a common presentation of these patients, normally missed. And then some of the SMAD, some of the rarer types of HHT can have aortic root dilatation and neuropathies associated with the genetics. And then they might even have some melena and some might have polyps. So just looking at a quick genetic overview. So there's 3 common genetic phenotypes or genotypes that are described, but they are not limited to these 3 alone. You have HHT type 1, which is part of the endoglin mutation. HHT type 1, which is the mutation in ACVRL1 encoding type ALK receptor. So endoglin and ALK1 is membrane receptors on the endothelial cells, whereas the SMAD4 gene mutation occurs intracellularly as part of the transcription factors. And the SMAD4 one is associated with the juvenile polyposis and a HHT overlap syndrome. And that has a whole story on its own. So that is a schematic representation of the percentages of how many have which mutation. And you can see the SMAD4 mutation is very small. Some papers actually say 1 to 3%. And they all form part of this big cascade, together with the transforming growth factor and BMP pathways. And they're very important, significant, and angiogenic balance of new blood vessels forming. And that's where it goes wrong. So what can it look like? This is not something often that you guys will see, but I know my medical colleagues might mistake this for even a MET from a primary cancer. But yes, this is an example of a big AVM. It can be a diffuse type, it can be multiple, it can be one large one, depending on how it presents in each patient. And it can actually differ within the same family as well. On the left of the screen, you can see a nice CT example of a pulmonary AVM in the lungs. And then on the right, the reason why I put this one in is significant in the pathophysiology of why we would see this. So this is a nice picture depicting a transthoracic cardioechogram done with agitated saline. So we call it a bubble study, where you inject, you mix the venous blood with agitated saline with air, and then you inject it on the right side, and then you watch the left side of the heart for significant amount of bubbles. This is an excellent screening tool in confirming a shunt or the presence thereof, but it is not specific whatsoever. It doesn't tell you where the AVMs are, how large they are, or how many there are, but it shows a nice picture as to why it's important for dental practitioners to know about this disease and to know if their patient has pulmonary AVMs, because that's how the bacteria moves to the systemic circulation. But more on that later. So these are a couple of examples of how it would look phenotypically in the oral mucosa and on the lips. They can get them on the face and around the ears as well. And they can look a little bit different. Some might be larger, some might be smaller. And they're different as opposed to petechiae, where petechiae might be a bleed or pinpoint bleeding, whereas this is actually a malformation of capillaries. And on the right-hand side, you can have angiotatic lesions as well, and these you commonly find in the GIT tract. On the left-hand side, we can see a nice example of a very subtle telangiectasia on the oral roof. So it can be very subtle. It won't maybe necessarily jump at you, but if you look for them, they can give you some clues. And then this is a nice example on the right of telangiectasia on the skin. So this is not necessarily something dental practitioners would have a look at, but the reason why I included this is an endoscopic evaluation of the nose of the HHT patients. And I just wanted to emphasize how bad it can get and why we need your help in identifying these patients. If you can just appreciate the malformations on the floor of the nasal cavity. And these things, as with those in the oral cavity, can bleed immensely on trauma, on irritation. These can bleed at any point and can cause quite significant hemorrhage. And the hemorrhage in the nose can actually lead to iron deficiency anemia and whatever goes with that. Okay, so implications for dentistry. So the first and foremost that I want to emphasize tonight is, and if it's only this one pearl that you can take home, is that you guys have a very privileged point of view. HNC is commonly associated, as mentioned, with this massive diagnostic delay and is under-recognized, but we don't look necessarily in the mouths where this is your scope of practice. Even if you can just pick one patient up, it will mean the world for that patient and that family. So the lesions are located in the dentist fields of vision. So 75% of HHT patients will have oral lesions. These are naturally described as macular and or papillar, and they're typically anywhere from 1 to 7 millimeters, and they may resemble petechiae. And you will discern petechiae from the telangiectasia based on the history. Some would have epistaxis, and you can discern that from the history. And why is this important? Is the early recognition and referral not might be life-saving, it will be life-saving for that patient and that family. Because the better the management, the better the prognosis. If we can pick up on the AVMs and do the screening mechanism and take care of the iron deficiency anemia, these patients' quality of life might be much improved. The second thing that's quite important for the dental health practitioner is that if there's a presence of pulmonary AVMs, they need antibiotic prophylaxis for dental procedures. So the stats tell us that about 25 to 30% of HHT patients will have pulmonary AVMs. And of patients in the world with pulmonary AVMs, 90% of those will have underlying HHT. So it's important to recognize the pathophysiology, to recognize the significance thereof. This creates a right to left shunt within the AVM itself, and that's pulmonary artery to pulmonary vein. So it's not pulmonary artery to bronchial vein, which then bypasses systemic circulation. So you have direct shunting of whatever is in that blood into the systemic circulation and then by association into the brain. And when you have a significant bacteremia, there's a concern for cerebral abscesses. So the Cure HHT group came together in 2009 and established the Cure HHT International Guidelines. And then they reviewed it in 2020. And still, even then, after the NICE guidelines, they still recommended antibody prophylaxis for procedures with the risk of bacteremia. And I think this is an audience that I don't need to stress the possibility of causing a bacteremia within your patients during dental procedures. So just a little bit of a look into the history and the guidelines. So our Northern Hemisphere French published the NICE guidelines in 2008, where they looked at the prophylaxis against infective endocarditis for dental procedures. And very well known to all of us is that they recommended initially that anyone with valve replacement, structural heart disease, previous infective endocarditis, stenosis, or regurg, used to get prophylaxis. But then in 2008, the NICE guidelines recommended, based on very good reasons, that there might not be a good reason to advocate it for anymore. Those included no consistent association between the intervention and the development of the AE, and regular toothbrushing also poses a risk to develop the bacteremia. So then they couldn't really prove the clinical effectiveness of these prophylactic measures. And it also poses a risk to the patient, maybe a fatal anaphylaxis, and it didn't prove to be cost effective. So I feel quite a little bit bold to say who are we to question the NICE guidelines. Then our colleagues from the UK, actually, Dr. Claire Chauvelin, who was the author of this paper, is quite the pioneer in the world of HHT. And they did a very nice review post-NICE guidelines publication in 2008 on what does this mean for HHT. So it's important to note the NICE committee and the American Heart Association did not consider people with pulmonary AVMs and the risk of the brain abscess in this population because it has a different pathophysiology, and that's the key here. It's essential to realize that the risk of brain abscesses for HHT is several orders higher than that for patients with heart patients and the risk of endocarditis. Due to the difference in the pathophysiology, you have direct shunting within these AVMs, even if they're small, that they can pass through from the right to the left side of the circulation and shunt directly into the brain. And for these reasons, they still advocate for antibody prophylaxis during any dental procedure or bacteremia-posing procedure for pulmonary AVM and HHT patients. So, and we need to emphasize, and we as clinicians try to do so, but I think our guys are in a much better position to just promote them to and educate them as to why their dental hygiene is of much higher importance. Not that anyone else's is less important, but they are at a true risk of brain abscesses. They did recognize, however, the need for further research within this field. Research in HHT is quite difficult because the cohorts tend to be smaller. So now we're saying antibiotics, but what antibiotics? I'm quite a big fan of the South African Antibiotic Stewardship Program and in the aim to prevent resistance. So as you all know, Streptococcus viridans is the group that we aim to prevent. And it's indicated in any procedure requiring manipulation of the periapical region and the gingival region and any perforation of the mucosal membrane. Some people advocate for antibiotic prophylaxis even for oral or dental checkups, anywhere where there's the risk of bleeding. And I went back to the books and then to the literature to see, what is the best recommendation. And unfortunately, the most recent ones I could still find was in 2014, which still recommended amoxil 3 grams PO orally, 30 to 60 minutes prior to the presumed or the manipulation of these regions, or as an alternative for your group that's penicillin resistant and or allergic, you can give clindamycin 600 milligrams IVI. The QR code is there for you guys if you would like to access this resource, and it will take you directly to a PDF that's downloadable from the SASP. But it's just note that it is still from 2014, and I would still recommend that you use your local guidelines wherever you practice, and just keep in mind that there is still a risk of resistance. Other clinical considerations is, as mentioned, the antibiotic prophylaxis, and I don't know if we have any MaxFax colleagues here, but if these patients go in for larger procedures and require multiple IV lines, they do advocate for IV filters for the paradoxical emboli risk. That said, it's just important to note that if you have an HHT patient or you suspect HHT and you can't prove post-imaging or with knowledge from the patient or the history that they don't have AVMs in the pulmonary circulation, I would still recommend giving the prophylaxis, even though it was not excluded just yet, because the risk of getting the abscess is higher than that of not. Just remember that it's a complex multi-system disease with a lot of aspects to think of, and screening is the key to success. And that's where you guys come in. If you can just identify these patients and refer them to your local hematologist, physician, depending, sometimes most of these patients actually present to the ENT surgeons. But you guys can help us quite a lot in identifying these patients. You'll probably save a life. Physicians' awareness is crucial, and to provide patient support and education. And just remember that even within the same family, it can look markedly different. One patient might have everything, and the daughter or the son or the father might have only AVMs or only epistaxis. So in summary, it's a complex multi-system disease And dental professionals have a vantage point in identifying the lesions and referring these patients to us. Early diagnosis is the key to success because then we can manage them and screen them. And as mentioned, the antibiotic prophylaxis, promote the dental hygiene and support to each other as physicians and healthcare providers in awareness and knowledge, sharing ideas, and also supporting our patients with the knowledge they need to go out and manage their disease appropriately. I just want to say thank you for this wonderful privilege to speak to you guys, and just thank you for giving your time tonight to listen to us a bit about the bleeding disorders and HHT. On your left-hand side, there's a QR code directly to the Cure HHT provider resources on the Cure HHT website. I don't have any disclosures with regards to them. I'm just a fan. And for our private colleagues, if you ever have to give an ICD-10 code as a primary code, why you're giving the antibiotics, or you're getting trouble from a medical age, these are some of the codes that you can use. All the references are available on request. You can feel free to contact me at any point should you want more information. And I just want to say thank you.
Thank you, Dr. Elzanne. Prof. Lowe, would you like to make any closing comments before I go into the Q&As?
Thank you, Dr. Nordine, and thank you so much for making us a part of your meeting tonight. I am really amazed by the number of people you've got in the room. It's really great to have this interface tonight educationally, but also in practice, to work very closely with our dentists in the management of their dental procedures. And I think having dentists around that know what they're doing in these cases is absolutely vital for our patients. So I need to just give a shout out to all the dentists who have made it their job to know how to manage these patients. Now, like many things, I think it's not only what you know, but who you know. And my number one piece of advice when you're dealing with bleeding disorders is to make a friend and phone a friend when you are faced with such a patient. HHT is a complicated disease and has a lot of elements that may not be part of the normal scope of practice of dentists, for instance, and we actually work as part of a very large multidisciplinary team, which Elzanne leads in Hereditary in our department, and there's a lot of specialized elements to it. So I think from our perspective, for me, that the takeaways here are: one, please help us identify these patients. We think that they are completely underdiagnosed. And what is amazing is if we find one patient, Elzanne and some of our other team members would trace the rest of the family and we screen them. And in this way, we've got a number of families now where we can really make a difference, identify these AVMs, treat the AVMs, make sure that when they go for their dental procedures, because all of them will go at some point, that they are prepared and managed well. So please, if you look into the mouth, you see those funny looking lesions, please send them to us. Secondly, and this I tell my medical colleagues as well, I think generally there's an over-reliance on laboratory testing to identify bleeding disorders. The very best test for a bleeding disorder remains a good history. And I almost want to say, in modern days, a lot of change has come in the world out there with regards to the prevention of catastrophes in the airline industry, etc., where we work with little checklists. In medicine, maybe it's the proud medical doctors that think they can remember everything. Unfortunately, I cannot. I think we should adopt this practice more, where we have little checklists nice little laminated, and there are wonderful little questionnaires developed that you just run through these things, or maybe your support staff or your nurse or whoever is with you, your assistant, runs through those questions and just make sure whether there could be a bleeding disorder. It can save yourself and the patient a lot of trouble. And once again, what a wonderful way to identify a patient. And many of these diseases being hereditary, once they're identified, they can come through to us and we can help manage them further. Those would be my major comments. I want to just say about the bleeding disorders in general. Make sure you have your contact at your local hemophilia or bleeding disorder center. We're very fortunate tonight, and I hope she will also make a comment or two, because the most experienced person in the country on bleeding disorder management around dentistry is actually sitting in the audience. Sister Anne-Louise Cruikshank. She leads she's part of from the International Society for Thrombosis Hemostasis, where she plays a senior role, and she teaches all over Africa. And I think she's worth knowing, and maybe Sister Anne-Louise, if you wouldn't mind sharing your contact email, because we also host on a regular basis dentists, surgeons, doctors who are interested in this. At the moment, as a matter of fact, we've got people from Kenya that come to us for a few weeks of exposure and training, and Sister Anne-Louise leads this. But I also think it's useful to know people like her, and she can give you contacts of the person closest to you. She knows everybody, that you can immediately pick up the phone. You must have your 911 somewhere in your rooms. There should be a little red or yellow card with your 3 top friends that you want to phone. If one is on holiday, there's always another one, and that will really help a lot. So those might seem like very basic things, but managing patients with bleeding disorders really starts with the basics. So thank you. 2 wonderful presentations by our colleagues. Really enjoyed it. And congratulations on hosting this meeting and on all the good work you do to educate your teams.
Thanks, Prof. Leo. Then we jump straight into, I see we've got quite a few questions. Our first question is, as a dentist, a patient has come after factor infusion, you do your procedure, for example, the extraction, but you notice that the patient is still bleeding after factor infusion post-extraction. What do you now do? Prof, do you want to tackle that?
Hello, Dr. Nordin.
Okay.
Sorry.
Go for it.
Orina, you're going to go for it?
Dr. Orina, please go ahead.
Okay, all right. So thank you so much. I think I can answer this question from Violet. So as a dentist, I'd first evaluate the cause of the bleeding. You could be, it's a vessel that is bleeding that, needs a ligation. So you first manage it with the local hemostatic agents that we discussed about. And if it's not working, if it's a big area, you can decide to suture that area. And you can also phone the hematologist near the local center to see if a nurse can come or anyone can come to up your level of factor. And there's usually tranexamic acid, which you can give after the procedure. Yeah, so first of all, manage it with your local hemostatic agents, suture if possible, but don't forget to consult the hematologist to see if they can up the systemic agents. Yeah.
Okay, thank you, Dr. Orina. Our second question is, what is the shelf life of the different components in the prophylactic armamentarium for treating a patient with hemophilia, which are essential that all dentists should have in their practice?
Okay, so the most common available agents are factor 8 and factor 9. So factor 8 has a half-life of 8 to 12 hours, and factor 9 has a longer half-life, which is about 16 to 20 hours. And the one you should have as a dentist is actually the tranexamic acid, the oral component. Usually has a half-life of about 2 to 10 hours, but it's usually administered 8 hourly. So in order for you to maybe do a prophylaxis, you have to consider the time you're doing a procedure. So the factors, the systemic agents are actually given by the hematologist or the nurse in charge. So for you as a dentist, what you really must have is the tranexamic acid, but you also have other hemostatic agents. So I hope I answered that question.
Thank you, Orina. The next question is, does HHT occur more frequently in any specific group, be it racial group or any other group? I think that's for you, Dr. Elzanne.
Yes, thank you, Dr. Nurdin. So unfortunately, the data we have currently is international data. So that is quite, it places us in a quite significant, and I think looking internationally, we can do quite a lot for HHT if we can answer that question, because it's a global question currently. From what we know internationally, data-wise, it doesn't seem to have a preference with regards to racial groups per se. And even in our clinic, in our small cohort, it doesn't seem to have any preference. I know there's HHT centers in Asia, there's HHT centers in North and South America and Europe. So from what we understand and the limited knowledge we have with regards to Africa, it doesn't seem to have a preference with regards to racial groups. I think there's a bigger difference in the age group at diagnosis as opposed to race per se. So in essence, to answer your question, it doesn't seem from what we understand at this current point with the research we have that it does have a preference. It seems to be across all racial groups.
I think just to add to that, Dr. Elzanne, do you think that you're seeing it now more so in kids or more so in adults?
So I think our platform might be, I think, a bit subjective in regards to practicing in GSH, because I know Red Cross have, I think Prof. Lowe can also speak to that, Red Cross has an active hematology department. I think so our referral base is more adult related. But we do have families that we do follow up that have kiddies with presentations that would be in keeping with HHT. I think the pearl is to identify the family and then to screen the kiddies. I think that's the best practice. And there are certain amendments to the screening procedures in the international guidelines that focuses a little bit more on less invasive ways of screening for the kiddies. But there are screening tools available for kids. You know. But I think in our referral bias. You know.
But I think the fact that you're doing the tracing would lead back more in terms of the families. So those kiddies are being picked up in any case, or if it's the kid presenting at Red Cross, and then the adults would be picked up in a similar fashion with family tracing. Yeah. Just a comment here from Sister Annie. She says, just a comment, we know bleeders are afraid of dentists and dentists are afraid of bleeders. So we appreciate our dental colleagues and really appreciate your assistance in seeing and managing these patients as part of the multidisciplinary team. So that was just a thank you and a shout out to all our dental colleagues. Let's see if there's anything else.
If you want to, I can comment on the COVID-19 question, if that is of interest.
Yes, Prof, you can.
Okay, so do you mind if I share my screen for a second?
Sure, no, go ahead.
Okay, so this is an issue that's come up regularly, and as part of the safety committee for the Sosonki trial, we've been asking exactly this question. Is there an increased risk of thromboembolic events with COVID-19 vaccination? And in this case, specifically, the focus was on the Johnson & Johnson vaccine. We're currently looking in more depth into the Moderna vaccine. But just to say, this was the one letter to the editor that we published, where we could show that there was definitely a connection with what is called vaccine-induced thrombosis and thrombocytopenia. But it is incredibly rare. We're probably looking at about 1 in every 250,000 people. Now, if you compare that to COVID-19, the disease itself, which I think, in my experience, must be one of the most prothrombotic diseases I've ever encountered. When we had the more serious forms of COVID, with many people ending up in ICU, more than half of patients who ended up in ICU, so more than 1 in 2, developed some kind of thrombosis or pulmonary embolism. So the disease itself is, in all likelihood, the most, let's say, probably the most significant risk factor almost ever seen for thrombosis. Nevertheless, we published this study very recently. This is updated data from the Sosonke trial, where we specifically looked at vascular thrombosis in healthcare workers. Now, one thing to recognize is, if you're vaccinating very large populations, you expect to, because now you're following these patients up very carefully, so you are going to pick up every possible complication, but we have to remember that there is a background rate, so an expected rate of something to happen. And in that way, there's an expected background rate of thrombosis. So what we did was we actually looked at our 500,000, almost 500,000 healthcare workers. And what we found were that there were 29 patients, 30 per 100,000, who developed vascular thrombotic events, as you can see here, at a median of 14 days after vaccination. And of these, most of them were women, and 51% of them actually had comorbidities that may have contributed to their risk. But then we looked at what we observed, compared to what is expected in the population. And what we see was that for cerebral venous sinus thrombosis with thrombocytopenia, that's the VITT, the one that I mentioned in this New England article. It's very rare, but that is definitely more common with the vaccine. But for everything else, there was no significant increased risk shown. Now, that said, we must remember that vaccination itself does cause inflammation, or an immunological response, which is also an inflammatory response. So any inflammation, whether it's from a vaccine or from an influenza or from COVID or from whatever, will increase your thrombosis risk. So my takeaway is that even if we saw a 10, let's imagine there is not an, we couldn't detect an increased risk. But even if we did, it's not nearly as much as when you actually get COVID. When you have COVID, your risk of getting thrombosis is very, very, very high. I hope that helps to answer that question.
Thanks, Prof. Low. I think that is something controversial that people are thinking about and going around. And I was going to keep it for the very last question. But let's move on to the very last question. There's one more, and it says, "Good evening, excellent presentation to the team. What is the opinion on patients taking aspirin for uncontrolled hypertension? Should it be withdrawn prior to routine extraction?" Anyone on the panel? Dr. Elzanne?
I think, Orina, if you want to maybe start and then and I'll respond.
Thank you. Thank you. Actually, I can actually give a comment on this. I think at the end of the day, you just weigh the risk versus the benefit for this patient. If you really have to do this extraction, then I think you always like have to weigh if it really benefits this patient. And then in consultation with the physician, you can check if they can reduce the dosage or, or whatnot. But let me give 2 illustrations. For instance, we know that calcium channel blockers, they can cause gingival hypertrophy. And so for you as a dentist, you're interested in maybe doing a gingivectomy to just reduce, the gingival hypertrophy. But again, this patient, the hypertensive patient, they really need these calcium channel blockers. So at the end of the day, you can't just tell the physician to withdraw these calcium channel blockers, because again, hypertension is, I'd say, like, it's more delicate than, the dental aspect. And my other example is on patients on warfarin. So let's say you want to do a dental extraction and this patient is on warfarin. You do not actually withdraw the anticoagulant, the warfarin, but you really have to consider, you take the INR. If it's really high, then is when you consult with your hematologist, so that maybe they can reduce the dosage. But for me, the point is really consider the, the risk versus the benefit. And for a patient with an uncontrolled hypertension, it's actually very risky to do an extraction. There are precautions, but just weigh and be in consultation with the physician is all I can say. Thank you.
If I just may add a comment, if I may, but I'm definitely going to put on my anesthesia hat now. If it might help just to know that from an anesthesia point of view, when we review the patient's pre-op meds, and aspirin is one of them, and it's for uncontrolled hypertension and the prevention and all of concerns of clots and etc. Depending, I think the essence of my response would be, it depends on the procedure. If there's and the degree of risk for that patient. There is actually some procedures that we do for general anesthesia, such as lab colis, that we actually don't stop the aspirin. And it's all, as Dr. Orina said, it's a risk-benefit ratio. But from an anesthetic side, where we do larger operations and larger interventions with a greater risk of bleeding, we don't necessarily stop it, as always. There's other agents that we do stop, like your Plavix or your antiplatelet drugs, and then obviously your warfarin and so on. But aspirin per se, if you take it at 150 milligrams as a cardiac preventative, it might not actually be as beneficial in stopping as the benefit of continuing. And I think it's really case-to-case dependent, and you would have to risk stratify that patient and assess the degree of risk of the procedure itself.
Okay, thank you. As a very last question we have, is HHT considered an AVM or more of a bleeding disorder?
Thank you, Noreen. I think this is a bit of I think it depends on how you look at it. I think it's a good question, and I think it can go either way, but I think in my mind, I always think of Virtuous Triad, which looks at endothelial mechanisms itself, and it assesses the blood contents, the flow of blood, and the blood vessel itself. And with regards to the pathophysiology of these lesions, the telangiectasia and the AVMs, it's a structural problem with a blood vessel wall, but it can cause bleeding when it's traumatized or fractured, or that poses a risk with regards to bleeding itself. But also you have hypercoagulable possibilities with turbulent flow within the larger malformations. So I think in that sense, if you look at it like that, well, that's how I look at it. It's definitely more of a combination, I think. But I think it's safe to assess it as a bleeding disorder in its entity, because if you look at what it can cause, it's all in keeping with the bleeding disorders. I don't know if Prof. Lowe wants to comment on that as well.
I don't think I would be able to answer it better.
Thank you, Dr. Elzanne. I think that brings us to the end of our evening. Thank you to all of our speakers for giving up of their time and for such an informative session, and then to all our SADA members for joining. Thank you so much, and enjoy the rest of your evening. Bye.
Thank you very much and bye-bye.
Thanks. Bye.